We gotta do it and stop talking about we trying.
I just wanna live a healthy life.
I know the benefits and how it make me feel.
I just wanna live a healthy life.
There's so much energy out here, I know it's real.
I just wanna live a healthy life.
Wake up, I got my tea boiling. Grand rising, no more good morning. Let's knock out what's important before.
What's up, viewers? It's your boy Mars, and welcome back to another Floor is Yours podcast. Today I'll be your host, and we got G here as always on the ones and twos. And then with us today, we got a special guest for you guys. It's a Black surgeon on the West Coast, Dr. Calvin Lyons, here with us today, and he's gonna obviously give us a little bit about him in just a second. But G, himself, he said we got to definitely get Dr. Lyons on here because, first of all, it's Black History Month. That's number one. Happy Black History Month to everybody. But then secondly, we have the opportunity to talk to a surgeon with a specialist that not many people actually talk about itself. And not only that, we get to talk to a Black surgeon in the community. So welcome, Dr. Lyons. And without further ado,
thank you.
You want to introduce yourself a little bit and tell the people a little bit more about yourself?
Yeah, good. Thanks, Mars. Appreciate it. So my name is Calvin Lyons. I'm a colon and rectal surgeon, also known as a proctologist, based in Las Vegas. I've been out here in practice now for about 7 years, and I'm very happy to join the show this morning and discuss with you guys things about colon and rectal health and colon cancer and screening, all those sorts of things.
That's good. We appreciate you. I just started. I know it's not one of those sexy topics, in this world where everybody is getting the what's the right word? Cosmetic surgeries.
Oh yeah.
And, things like that. So when it comes, and it baffles me that we'll spend, those things aren't even covered by insurance, but these things are. But we won't even, for whatever reason, not take care of ourselves in that arena. So hopefully we can help dispel some of those stigmas and rumors and whatnot, and just help educate the people so we can, take better care of ourselves.
Yeah, for sure.
That's actually very interesting. Very interesting. You said that, G. That is very true as well. That often people worry about cosmetic surgery and not really so much the different wellness and health. So I say maintenance that we should be worrying about most. That people spend thousands on cosmetic surgery and won't spend they don't have to spend anything on their wellness, but still won't pay attention to that.
Yeah.
So would Doctor, speaking of that, Dr. Lyons, how often do you feel like you have to, not necessarily beg, because we want to say you're beg, but you plead with to care about their actual physical health?
Yeah, well, health prevention in general is really key, kind of like what you guys mentioned a second ago. These are sort of things that you do to prevent, future illness and, morbidity and, sickness. And so it's not something that people tend to focus on and can be ignored and overlooked. And so, I get people come into my office for all sorts of issues. But one of the things I try to do is to make sure that if they're of age, meaning if they're 45 or older, and they have not had a screening colonoscopy, that I mention that to them and I discuss the procedure with them in detail and try to convince them to go forward and schedule the procedure. So, just so you guys know, colon cancer is the third most common cancer in the Western world. About 5% or 1 out of every 20 people will develop colon cancer or rectal cancer in America. And so because it's so common, we've come up with a way to sort of screen for it and also to prevent it from happening in the first place. And the procedure that we consider the gold standard is called a screening colonoscopy. Okay, and so that's a procedure where we put you to sleep for about maybe 20 minutes or so, and we use a flexible camera and we look inside your rectum and your colon to make sure that you don't have a cancer or a precancerous polyp. A polyp is an abnormal growth in your colon. And so if you do have a polyp, we can remove it during that procedure and minimize your risk of developing colon cancer in the future. And so it's something that we try to make sure the public is aware of and people understand at what point they're supposed to have one done. The age is 45. Okay, so for the longest time, it used to be 50. But in 2018, the American Cancer Society dropped the screening age down to 45. And they changed the age primarily because over the last about 25 or 30 years, we've discovered that colon cancer has been increasing in younger and younger people. So it used to be a cancer that would, and still occurs most often when you're, above the age of 50, 60 years old. But the incidence of colon cancer in individuals in their 30s and even early 40s has gone up dramatically during that time. We don't know the exact reason why, but we suspect it's probably due to our diet.
Yeah.
And so for that reason, they decreased the age to 45. And, anybody that comes in and they're 45 or above and haven't had it done, I take care of their primary issue, but then I also had this discussion with them about having this procedure done. Really, it sounds corny, but it can really save your life. We can prevent it. And we're lucky because colon cancer is one of the few types of cancer we can prevent. Not every cancer has some sort of screening test that we can perform to prevent it from happening in the future. And so, we have that benefit. And so if people are aware, I truly encourage them to get it done. If anything, is peace of mind. From my standpoint, I got a wife and kids, and I really want to see my grandkids, and if God's will, my great grandkids one day.
Right.
So I personally want to take care of myself and do all those things that I can to ensure that I'm healthy and I'm alive and well in years to come.
So you talked about the polyps. So and I remember, just so the audience knows, we actually met you when we was doing the men's mental health back in Vegas, and I remember you talking about those polyps, and I can't remember if you said, is it a certain, like, if you have polyps that they will develop into cancer?
So it's not guaranteed. Most polyps will not develop into cancer, but if you have a cancer, for sure you had a polyp before it actually turned into a cancer. So a polyp is a precancerous growth in most cases. There are some polyps which are benign, meaning they're not cancerous or precancerous, but the majority of them are. And so we can look inside your colon and we can see them with the camera, and then we can remove them using that flexible camera at the same time. So it can be both what we call diagnostic and therapeutic. We can actually do something at the time of the colonoscopy to remove that polyp and then minimize your risk of getting cancer in the future.
How many, that was a good question, G, because I wanted to talk about those as well. The polyps, how many of those would you say you're removing monthly?
Oh, a lot. I mean, about 25% of people will have polyps when they have a colonoscopy performed. So they're pretty common. And about 30% of men and 20% of women will have polyps. So overall, it's about 25%.
Oh, wow.
Yeah, that's pretty good. Because even though you said that most of the time polyps don't develop into cancers, but you said the cancer, it
If
starts
there's a cancer there,
right? So let's say, even if just 3% of the polyps that you remove turns into cancerous, that's a lot of life-saving.
yeah, for sure. When you look at it that way, that's most definitely true. And that's what I try to, discuss with patients. And most people are very receptive. When they know, they're like, oh, okay, doc, sure. It's important. I'll get it done. Occasionally I have folks that are kind of skeptical, and, I just try to inform them. At the end of the day, I tell patients, you're the captain of your own ship. You can do what you want to do. My job here as a medical professional is to inform you, and then you can make an informed decision and decide what you want to do. Now, there are other ways to screen for colon cancer besides a colonoscopy. I want to make sure that the audience understands that the gold standard is a colonoscopy because it is the most accurate, and you can also remove the polyp at the time of the procedure. But if you, for whatever reason, are apprehensive about undergoing the procedure and taking on the associated risk, then there are other modalities that we can use to screen for colon cancer. So one of the other most common ways is to do what we call Cologuard. So Cologuard is a non-invasive colon cancer screening test. So it's a test where they actually send a box to your house, and then you put a stool sample in the box and you package it up and mail it back to the people. And so they look at your stool sample and they look for the presence of tumor DNA in your stool. And so it's pretty accurate. It's not as accurate as a colonoscopy, but it's pretty accurate in determining if you have a colon cancer or precancerous polyp present. Now, there's a couple of caveats you have to understand. Number one, as I said, it's not as accurate. So there's what we call a false negative rate. So a false negative means that you actually have a colon cancer. You perform this test and it gives you a normal result. That can happen in about 8% of people. So in other words, if you had a room of 100 people, you knew for a fact had colon cancer, and those 100 people did a Cologuard test, 8 of those people who for a fact had colon cancer would get a normal result. And so you kind of have to keep that in mind. There's also a false positive rate. So there's about a 12% false positive rate where you get a Cologuard test done, it has a positive result. And if you have a positive result, then the next step is to undergo a colonoscopy anyway. And so you can end up performing the procedure in that case, the colonoscopy, to look for a cancer, and there's nothing there. So if you're going to do a Cologuard, you have to kind of keep those things in mind.
Yeah.
If you're going to do that test. And it's also not available to you if you have a family history of colon cancer, or if you yourself have had polyps in the past. It's only for people who have no family history and no personal history of polyps.
Mm-hmm.
So with the polyps, do you remove all of them? My first question, you remove all of them if you're in there? And the other one, you're saying you're going in there not knowing if you're going to find them. So you have this conversation with the patient before, where they know, like, if you find them, you're going to remove them.
Yeah. So sometimes they ask me, say, "Hey, doc, so if you find something, they're going to remove it and take care of it at the time?" I say, "Yeah, if we can. In most cases, we can remove the entire polyp. There are some cases where the polyp itself is just too big to take out, and that's that can kind of create an interesting situation. In that case, if we can't remove the entire thing, then we get a piece of it, get a biopsy of it. So you can take a little tiny piece of it or a couple of biopsies of it to determine what it is. And then what I'll usually do, if it's a larger polyp, I will tattoo it. So I actually put a tattoo in the colon. And I do that because sometimes you end up in a situation where there's a polyp there, you cannot remove it. And so you have to do surgery to remove that portion of the colon. Because that polyp, if it's not removed, even though it's not cancerous, it can turn to a cancer in the future. And so that part of the colon has to be removed. There's also something, I don't want to get too much into the weeds, but there's something called a sampling error. So in other words, if I see a polyp and I take a little biopsy of it and it's analyzed by the pathologist, that biopsy may come back to normal. But that doesn't mean that polyp is definitely not cancerous. So if you imagine a tumor the size of the room you're sitting in right now, and I took a little piece of that tumor between my fingertips and was analyzed by a pathologist, it doesn't mean that there's not cancer somewhere else within that big tumor. That little piece I got may not contain tumor, but there may be cancerous parts of that big mass somewhere else within that big tumor. And so you have to, basically what I'm trying to say is that when you have a polyp that's that large that it cannot be removed, we treat it like cancer until proven otherwise. So in most cases, we're going to go and do an operation to remove that part of your colon, and then have it looked at by a pathologist to get the final pathology once that entire piece of your colon is removed. That doesn't happen a lot, but it does happen. And so that's just one of the things we have to discuss if we ever encounter that situation with the patient.
And so there are times, I guess, that's when you don't know if there's cancer. So if there's cancer in there, sometimes you do have to remove parts of the colon.
Yeah, for sure. If there's a definite cancer, and oftentimes we can tell, when you look at a big mass or a big polyp in the colon, you can oftentimes just tell visually that, okay, this is highly likely to be a cancer. We always confirm with the pathologist. We always get a biopsy and send that tissue to the pathologist, and they examine it under a microscope, and they issue a report, which usually comes back in like a week or so. And so once we know for a fact that it's cancer, then we proceed forward with the cancer workup. So they get sent to an oncologist or a cancer doctor. We also get imaging, CT scans and stuff like that. And then if there's no spread of the cancer to other parts of the body, then we proceed forward with surgery. We take out that portion of your colon.
So you talked about quite a few other disciplines, if you will, that you work with. You talked about the pathologist. So, just for me, my understanding, what does it look like if something comes up? Like, who all do you refer them to someone else first, or now this is in your lane and you're taking it from there?
Yeah. So when you have, these patients where you perform this procedure on and you get a diagnosis of cancer, I'll work with a number of different specialties. Oncologist, the cancer doctor, the pathologist is also very important. And we usually develop a plan on how to best proceed forward. So after we get a diagnosis of cancer, the next step is to stage. So when I say stage the cancer, what I'm referring to specifically is getting a CT scan and getting blood work with the primary goal of determining if there's stage 4 cancer. In other words, if the tumor is spread to other parts of the body beyond the colon. Because if that's the case, then surgery is not indicated as the next step in most cases. You would get chemotherapy. But most people are not stage 4 disease. About 25% of people who have colon cancer will have stage 4 cancer on diagnosis, but 75 won't. And so 75% will not have stage 4 disease. And so those people are eligible for surgery. And so once they've been staged appropriately, if it's a colon cancer, usually surgery is the next step. And, we discuss the operation in detail in my office and we proceed forward and get it done. Rectal cancer is a little more complicated. Sometimes, depending on where the tumor is in your rectum and the stage, you may get chemotherapy and radiation therapy before surgery and then have surgery afterward. So it can get kind of complicated. But generally speaking, you get the diagnosis of cancer. They see an oncologist that gets staged appropriately. And then if they're a candidate for surgery, we proceed forward and do the operation.
Yeah, it's a lot. Mars, you got anything you want to?
Yeah. How often do you guys do the colonoscopies? So even the colonoscopy. So like even if let's say you did a I know you do follow up, but let's say you did a colonoscopy and you remove some polyps. What literally essentially when would be the next time? Not the follow up, but like how often you ask?
Yeah. So that's something that, I really try to focus on communicating with patients, because I receive patients from other, people that had, a colonoscopy done 5 or 10 years ago. And I'm like, well, what did the doctor tell you? I'm like, I don't remember. I don't know if they told me anything, so it's really important to discuss with your doctor after you have the procedure performed, specifically when you should repeat it again. And so that depends on the pathology from the polyp, and also the size, and also if your family history and your personal history. So if you have a very large polyp and it's a certain subtype, I may have you come back again in a year or 3 years or 5 years. And so to answer your question, it can vary. It depends on the size, and it depends on the pathology, and it depends on your family history and also your personal history. And so those 4 things we kind of take into consideration when we're counseling a patient on when to have it repeated again.
It's a lot to consider. And I'm asking because my question was, like, I know there's a lot tied into it, and we talked a little bit about prevention and not just own personal discussion. And there's you mentioned that one of the reasons that they lowered the age was there was more younger people, and you talked about maybe in the diet. I mean, what was that for certain, or do you have any information to share? Like, is it our diet, but in our diet can affect that?
Yeah. So there's a strong suspicion that it's diet that's causing these earlier onset colon and rectal cancers. Specifically, there's certain risk factors for colon cancer that we discuss. There's some that are called modifiable risk factors and other ones that are called non-modifiable risk factors. So the ones that are non-modifiable are things like your genetics, your family history. You can't change that. You were just kind of born with that. That's not going to change no matter what you do. As far as modifiable risk factors, these are things that are like part of your lifestyle. And so one of those is your diet. So diets that are high in fats, specifically saturated fats, and red meats are definitely can definitely predispose to colon cancer formation.
Oh, wow.
Yeah. So other things, smoking is a definite risk factor. High alcohol consumption is another risk factor. Sedentary lifestyle, lack of exercise is another risk factor. A lack of dietary fiber, can also predispose to colon cancer. And so these are things that are within your control, so I really try to encourage patients, not to smoke. Smoking is always bad for anything, but even beyond colon cancer, it's a risk factor for all kinds of cancers beyond lung cancer and colon cancer. Minimize alcohol, really try to, exercise. It's going to provide all kinds of benefits for health beyond just your colon. And then try to get fiber into your diet. So myself, I personally take a fiber supplement every morning. Either something like Citrusel, Benefiber, Metamucil. You can find these fiber supplements in the constipation aisle at the pharmacy. Any CVS, Walgreens, Walmart, Target. You can find some sort of fiber supplement. And so I just take 1 tablespoon, I mix it up in a glass of water first thing in the morning, every morning, and I drink it. Most Americans do not get anywhere near the amount of fiber they need. And so easy way to get it in the first thing in the morning, and you just go about your day. And it can also, it's very helpful with preventing constipation as well.
So fiber itself, because I've heard that several times. You got the Fiber One or whatever, like they trying to push fiber, at least the last 5 years. But is that a preventative, or is it just a balance out? of what you're already doing? Like, what does fiber do for to reduce pollens or cancer in the colon?
So I don't know if the exact mechanism is known, but a fiber is known to draw water into your gut. And so it helps keep your stool soft. It helps prevent constipation. As far as the specific mechanism on how it prevents polyp or cancer formation, I don't know that it's known, but we do know there's an association between increased fiber intake and also colon cancer.
Wow, that's good.
Yeah.
You was talking earlier about the red meats and alcohol,
Yeah.
and I think about you mentioned the West, and
Yeah.
they say some things as American as apple pie. I think you can almost put that in exchange apple pie for steak.
Cheeseburgers, right? And hamburgers,
And I
French
just think
fries, yeah.
about just our whole structure and how we're on the go and what do we have time to eat. Like, it really takes us to be intentional about prevention and our health to make waves in that space.
Yep.
Which, the fortunate thing is that we know it, but the unfortunate thing is that people just don't take it serious. And I'm talking about myself now.
No, you're right. You're right. We get told like, yeah, got it, and then 5 minutes later, they're focused on something else, and they totally forget about it.
Oh, I ain't got time.
Things, they not have time, right? And so you have to like you said, it has to be intent. Like, you have to prioritize this in your life. You got to sit down and like write out a plan. I mean, for me with stuff like this, what I do personally, I put an alarm on my cell phone. So I mean, it's just something that goes off every morning, and then once I build a habit, it's not necessary anymore. But once that alarm goes off day after day after day for 3 weeks, a month, couple months, whatever it is, then it just becomes routine. Now you've built a routine, and it's even in your subconscious that you don't really have to think about it anymore. But to really make that change, you have to make it a priority in your mind, and then do something to trigger yourself to follow through. If not, it's gonna be one of those things you kind of hear it, you interpret it, and then you forget about it. So it's just taking initiative to focus on your health, and then finding ways to incorporate that into your day.
Yeah, like you said, that intention, G, and the one way most of these companies are multi-million to billionaire companies is they're banking on us not being intentional with our health, and it's that simple.
Yep.
It's unfortunate. But it's the truth that we need to realize it. But it's self-accountability. Responsibility first is my responsibility, and then accountability that comes with it as well. So
nobody's going to care about you more than yourself. So
self-love,
right? Self-care.
Yeah, absolutely. I'm the main person for self-love and self-advocacy for sure. G, did you want to go ahead and go to a break?
Yeah, let's go ahead and take a break. We'll come back from the break and we'll continue the discussion.
Hey, baby. I'm just gonna check in on you. How's everything going?
Hey, Mom. Everything's good. Are you headed to meet the new client?
You know it. I have a feeling they're gonna like what I have to show them today.
Well, then I know you're gonna kill it. I love you so much, and I'm so proud of you.
Oh, thank you, baby. I love you too. I'll talk to you soon.
Deborah Jones is back in the news again. I've got to say, she's got some ego.
She's way too aggressive.
The risk she takes in this market, you wouldn't catch me doing that.
I've seen more humility in a peacock.
Who does she think she is?
Deborah's integrity and honesty shine through in every transaction.
Her dedication to the client is unmatched.
She is really a visionary, always one step ahead in the market trends.
You'll never work with a more dedicated and resilient agent.
I love you so much, and I'm so proud of you.
Hi, I'm Deborah Jones, broker owner of Nair Realty. My mission is to elevate your real estate experience through personalized solutions guided by integrity. So call me. Now is your time to shine.
All right, welcome back, everybody, to the Floor is Yours podcast. I'm here again with Dr. Calvin Lyons, and he's giving us some gems about our gut health because it's very important. We don't talk about it. We don't think about it. And like we said before the break, and G said, being intentional is the best part about what makes us healthy. What brings wellness to us is actually being intentional, setting plans, setting alarms, like Dr. Lyons said. So speaking of which, I'm the mental health advocate myself. So, we always got to bring that into whatever topic we have because it's very important. But have you seen any connections between gut health and mental wellness, or does gut health affect mental wellness in any form?
So the mental health aspect is not something I focus on a lot, but I do know that just dealing with things like colon cancer and cancer in general can be mentally taxing on patients. One of the things that I do sometimes in my surgeries is I have to give people stomas. So when I say stoma, I mean I have to bring up part of their intestine to the abdominal wall and have a bag. That doesn't happen a lot, but it does happen occasionally. And as you can imagine, that can be mentally taxing on patients. When I mention that to them in the office, sometimes they don't respond very well for obvious reasons. And so there are support groups for people with stomas, where they meet, once a month, and they just talk about different things pertaining to the lifestyle dealing with the bag, and so that's sort of a community that can kind of help them adjust to that new part of their life and help them deal with that mental anguish, so to speak. And surprisingly, I have a few patients that need them, permanently. And when that does occur, after a few months, most of them adjust pretty well. It's really surprising. I mean, I've seen patients where I mentioned to them and they just kind of almost fall apart in my office. And then we perform the surgery, and a year later, they're like, yeah, this is no big deal.
Oh, wow.
And so, with the proper support, I think most people can make that adjustment and deal with that particular issue. But beyond the stomas, just dealing with cancer can be really challenging. And, I don't deal with the mental health aspect of it. I imagine the oncologist, the cancer doctor, probably does more so than myself, because of my specialty being a surgeon, I don't usually follow people for, a long, long time. I have an issue in the moment. I diagnose them, I treat them, I make sure they recover from the surgery, and then they move on. Sometimes they come back to me to have another scope done in a year or 3 years. But that's like a very short interaction. But the oncologist is their best friend. So you get a diagnosis of cancer. It doesn't matter what type of cancer it is. There's what we call surveillance. It's when the patient is followed over a period of time to monitor for signs of cancer recurrence. Because I can perform a very successful surgery. I can remove the entire tumor. All my margins or my specimen are negative. There's no signs of any cancer left behind. And then it can have a recurrence in a year, 2 years, 5 years, 10 years, whatever it may be. In most cases, at least for colon and rectal cancer, that recurrence occurs within the first 5 years. And then most of those recurrences will be within the first 2 years. And so it's very important to have an ongoing relationship with your oncologist. And so once diagnosed with colon and rectal cancer, they're usually going to see their oncologist every 3 months for the first 2 years, and then every 6 months for the next 3 years, so up to 5 years. If you have not been diagnosed with recurrence in 5 years, the chance of it happening is very low, and you can discontinue the surveillance visits. And so, for that reason, the oncologist has a very close relationship with the patient beyond my relationship with him. The patients are very appreciative, and I pride myself on being very understanding, communicating very well with patients. Just trying to be empathetic with their situation and make sure that they understand what to expect as you go forward, because having cancer and having surgery and with possible issues and complications can just be very overwhelming mentally and emotionally. And so I always keep that in mind when I'm interacting with patients. I always try to speak with them respectfully, and just make sure they're not afraid to reach out to me. Sometimes, unfortunately, some docs have a reputation for being impersonal and just not really caring, and I'm always acutely aware of that when I interact with patients, and I try not to come across that way. And so I do the best I can to advocate for them and to be empathetic and understanding of their situation. But once my part is done and fully recovered from surgery, they move on and they interact more so with the oncologist. And so the oncologist probably has different mental health issues they deal with commonly, and they probably have resources at their disposal to kind of guide those patients in the right direction.
That's good. That's good.
Yeah.
So typically, before they come to you, are most people referred to you by their general practice, or do some people come to you from the jump?
So most of my referrals are either from the gastroenterologist, because they also perform colonoscopies, as well, and they diagnose the patient, and then the patient is sent to me for further workup and evaluation.
Okay.
I also get some that are referred from the primary care doctor, the general practitioner, and then occasionally I also get some referrals from the oncologist. So those are the three specialties I get referrals from most often: either oncology, gastroenterology, or their general practitioner.
Yeah. Now I was asking, just trying to wonder, like, is there a like maybe what's the word I'm looking for, a funnel or a bottleneck somewhere where it's difficult getting the care that you provide from I don't know,
Yeah.
access, advocacy, or something like what would keep people from getting the care that they need?
Um, sometimes there are issues with insurance. I mean, occasionally I get referred a patient, for a certain diagnosis, like a cancer diagnosis or something, and I look and I can't see them. That was an issue with my former group. My current group takes pretty much every insurance plan in town, and so I should be able to see most patients. That should not be an issue. Um, sometimes, patients not really being aware. Again, the communication thing can be an issue. I've had patients come to see me and they have a colon cancer and nobody told them they have cancer, which is awful. It happens rarely, but it does happen. It's happened to me more than once. And so I'm seeing the patient in my office, I'm sitting down so Dr. So-and-so sent you to see me because they found a cancer in your colon, and they kind of give me a strange look. And in that moment, I'm like, oh my God, nobody had a conversation with the patient, So sometimes stuff slips through the cracks and things aren't communicated well. Again, it doesn't happen a lot, but it's happened to me more than once. And so, because it's happened to me when I sit down with a new patient, especially a cancer patient, when they come into my office, the first thing I say to them is that, do you know why you're here today? Do you understand what's going on? So kind of get an idea of what they've been told and what they understand. That way, when I'm speaking to them about this, because at that point, when I say, oh, you have a cancer and nobody said it, they're not going to interpret what I'm saying. It's like Charlie Brown voice, wah, 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 wah. Their head is spinning, their heart is pounding, and so I hate that. And so I've changed my, the way I interact with them when they first come in and see me for the first time. I have a specific way that I kind of go through things. And universally at this point, I always start off, do you know why you're here today? And I kind of make sure that they understand at least somewhat what's going on. And then based on what they understand, that's my starting point for how I approach the conversation going forward.
So yeah, that sucks, and
it does.
But it definitely answers their question, because I know that obviously the gut is so much, and the colon is so much further from the brain. However, you already show it just in your own personality and your own caring for your career that you care about people's mental health. There's always going to be a connection.
Oh yeah,
even
mental
especially
health is very important.
What you're going through, and even you said that with going through the issues with a lack of communication. You don't want to be the first person to just say you have cancer. You know what I mean? And so even you kind of changed your approach, but to just let some people know, and I don't know if you knew, Doc, but the brain and all the organs communicate. They're sending signals back and forth
constantly. Yeah.
What you've heard, and we all heard, you are what you eat, because you are, and you mentioned it several times, that the correlation between the age group going down because of the food intake and the changing and all of that. But yeah, so like even if you are eating bad stuff, if you are having cancerous polyps down there, the gut is sending that to the brain, and so you're out of there. Some of these things and these chemicals going on in the brain will change and alter your whole mental health. So yeah, definitely there is a connection, and it's sad that most people don't really look at it that way. That's even a bigger reason than these, because I'm putting air quotations because they are there, they're real, but these polyps, because people can't see what you can't see. Most people can't. You're fine, like.
Yeah.
If you ever had car issues, you can't say whatever. Let's go. Put some gas in it and let's go.
Yeah,
I definitely understand that for sure. But with that being said, though, there aren't many, I guess, in front connections between mental health and the gut. Can you say that there are or connections between race and gender with gut and things you've seen in your office?
Yeah, well, unfortunately, there's a higher incidence of colon cancer in African Americans compared to the population as a whole. Could be possibly genetic component. Can also be socioeconomic factors. Just people's just having health insurance and ability to go to a doctor. Is a major hurdle for many people. It's also just awareness. People may have insurance, but I've seen some especially black men. I don't like going to a doctor. I'm not going to a doctor. I see some men that get dragged in by their wives. just because they don't want to go. They're too proud. They're afraid to get bad news.
Yeah.
These sorts of things. Man, if I had $1 for every husband that came in with their wife, and the wife is all over them, and the wife knows more about their own health issue than the man patient does himself, I would be a rich man. So there's, different perspectives. I mean, there's still some distrust of the medical community among Black folks. Honestly, the Tuskegee experiment is something I hear about not infrequently, and that lingers to this day. I mean, I have folks in my own family who don't trust doctors, and I got to fight with them to go, just because there's just this extreme level of distrust. And so these things all factor into people's ability to go to doctor, to get the proper testing done, and to get diagnosed. And for these reasons, they get diagnosed more frequently and also at a later stage of cancer. So, for example, if you came in the first time you saw some blood in your stool, that can possibly mean that you can have your cancer discovered earlier on, which means you're going to have an earlier stage cancer, stage 1 versus stage 2 or stage 3. The longer you wait, the longer you sit on symptoms, the more likely the cancer is to progress. And, so all these things, matter. And if you present with a later stage cancer, your chance of having a good outcome goes down, so all these things are connected, and it's just a matter of, trying to raise awareness and really trying to reach out to different communities to make sure that they're aware of what needs to be done as far as health prevention and health maintenance. And they're not also afraid to come in and to be, examined. And so I'm doing as best I can to raise awareness. It's part of the reason why I'm here on this podcast today. I just want people out there, if they're listening, to feel comfortable coming to a doctor. We're human beings just like you are. We have feelings and emotions, and we care. I mean, medicine is hard, and it takes a lot to become a physician. And people would be doing this if they didn't actually care about what they did. So we're on your side. Don't be afraid to come talk to us and to be honest with us, and to trust us to take proper care of you. And honestly, if you have a bad interaction with one doctor, don't let that spoil the bunch. Don't let that one bad experience with that one doctor, change your perception of doctors in general. Go see somebody else. But the answer is not to sit at home and not pursue proper health care. All you're going to do at the end of the day is harm yourself.
Absolutely.
Yeah. Hey, can you talk? And earlier you talked briefly about the procedure, but can you give us a little more insight on what that looks like and what they can expect? Like, what does it feel like? The recovery period? All that right there.
Yeah. So if you do, end up getting diagnosed with a colon cancer, finish
just real
staging.
Quick, maybe on both of them. So the colonoscopy and the
the colonoscopy. Yes. So for the colonoscopy, so the day before you have to do what we call a bowel preparation, a bowel prep. So it's when you take some pills or drink some liquid that's going to clean you out. It's a very, very strong laxative. And so, you're going to spend a good amount of that day on the toilet, get you cleaned out.
That sounds painful or uncomfortable, to say the least.
No, it's not. I've had it done before myself, and it's not painful. I mean, you got to go, have some diarrheal stools, but it's not too bad. I mean, some people react differently than others, but most people get the bowel prep down without a problem.
And you're not eating, so it's not just the bowel prep, but you got to stop eating.
Yeah, so there's some dietary restrictions as well. And so we typically, for my preps, the patient can eat breakfast the day before, but around noon, you're going to switch to a clear liquid diet. So things like water, juice, Jell-O, Gatorade, stuff that kind of consistency, clear liquids. And you can drink clear liquids up until midnight. And it depends on the bowel prep you take, but from noon going forward, you'll take one of a number of different preps, and you'll get instructions from your physician. And then after midnight is usually when you stop drinking anything. Sometimes there's a second dose of the bowel prep you take after midnight, a few hours before your actual procedure. But again, it varies. So you show up that day for your procedure. In most cases, it's done at a surgery center. Sometimes it can be done at a hospital. And then you speak with the doctor who's going to perform your colonoscopy, and also the anesthesiologist. So there'll be another doctor there, anesthesiologist that's going to put you to sleep and monitor your blood pressure and your heart rate, all those kind of things during your
just real quick before we get to it, do you try to have it early for people who like me who like to eat? If you don't want to sit around all day, you don't want to sit around all day and starve, then you probably want to try to prioritize having it done in the morning. So it depends on the doc, but my earliest one, I do something from 7 o'clock going forward, 7 a.m. going forward. Okay.
So yeah, you want to eat, then have it done in the morning. But yeah, you show up, you talk to us. We take you back into the GI suite, and in most cases, it's going to have you lie on your left side, put your knees up to your chest. They give you some medication to kind of put you to sleep. It's called propofol. There's no breathing tube, so it's not like surgery. It's not a surgery; it's a procedure. And so you get medication through your IV, and you kind of just drift off to sleep. And next thing you know, you wake up and you're like, you guys are already done. I just fell asleep like 2 seconds ago, you know? So when you wake up, you feel like you had a very restful nap. But during the procedure, I'll look around your entire colon, your rectum. I'll make sure I don't see any polyps. If I do, I'll remove them. If there's anything that needs to be marked or biopsy, we'll do that too. And then we're done. And then after you wake up, I come and talk to you in the recovery area. I'll let you know if I found something, what it was. But at that time, I cannot give you the exact result. So the specimen, if I took a biopsy, then that has to be examined by a pathologist, and they'll issue a report, which usually comes back about maybe 10 days later.
How long is that surgery?
So it's about half an hour duration.
Without anything.
What's that now?
Without taking any specimens.
Yeah, so usually, I mean, I tell patients half an hour, but in most cases, we're usually done about 15 minutes. It's not very long.
Okay.
Yeah.
Okay.
Yeah.
So what is the mortality rate if it does turn into cancer? And I know there's some variation. Catch it. Is it pretty correctable? I don't know if that's the right word to use.
So yeah, so it depends on the stage. So the earlier the stage of the cancer, the higher your survival rate. So for stage 1, it's about 90%. For stage 2, it's in the upper 80s, 80s. There's multiple different, we call subtypes of or substaging. So there's stage 1, stage 2, and there's 2A and 2B and all this stuff. It gets really complicated. But for the most part, for stage 1, it's about 90%. For stage 2, it's in the high 80s. Stage 3 is somewhere in the 60% range, or it could be 70% with if you get chemotherapy. So stage 3 cancer, stage 3 colon cancer and rectal cancer, those patients typically will receive chemotherapy. There are certain exceptions for stage 2. Most do not receive chemotherapy for stage 2, but there are certain exceptions to that. And so if you receive chemotherapy, it's going to increase your survival rate. Okay. And then stage 4, it's about 13%. And this is like over the course of 5 years. So all those numbers are quoted over the course of 5 years. So for stage 1 disease, 90% of people are still alive 5 years later. You know, for stage 4 disease, 13% are still alive 5 years later. And so, you know, it depends on this. That's why you want to come in and be screened. And so this is something else I want to make sure the audience understands too, is that I've heard people say several times to me, Doc, I don't have any symptoms. I don't think I need to have this procedure done. That train of thought is really bad, primarily because about 25% of people, about 30% of people will have no symptoms at the time of diagnosis. So you may have a colon cancer and have no symptoms. It is possible. It is not uncommon at all. And about 25% when they're diagnosed with colon cancer will have stage 4 cancer. So 1 in 4 will have stage 4 disease already. Wow. So this is not something you wait around until you have symptoms. I've seen, you know, there's a lot of stuff on the internet you can't really trust. And I've seen some videos of supposed, you know, experts. Some of these guys are quacks, to be honest with you, telling patients don't go in and have anything done unless you have symptoms. It's all a scam. They're trying to make money off of you. You see this stuff and people don't know. You know, people are, you know, one guy's talking, he says he's an expert. Who am I? They listen to me. They don't know who to trust. Yeah. So I just want to be really clear about some of this stuff. Like, you do not want to wait until you have symptoms. Go when you turn 45. If you have a family history of colon cancer, it could be actually before 45. You know, it depends on your family history. So have that discussion with your primary care doctor, your general practitioner. You know, if you're not sure, say, hey, doc, do I need to have one done? Is it time for me to undergo a colonoscopy? You know, and they should let you know. If they don't bring it up, you should bring it up. You know, this is, again, part of advocating for yourself. But to be clear, don't wait until you have symptoms. You want to go at the appropriate time. For most people, it's 45. If you have a family history, it could be less than 45. And get it done.
So it's good that it's preventable. You know, you can catch this
yes,
early, but
it's one of those few cancers which are preventable. We have that advantage in this case.
That's awesome. So, but the second part of that question, like, are there symptoms when it do,
Yeah,
that we could
yeah.
potentially look for?
So symptoms to look out for, blood in your stool, that persists. Everybody can have a little bit of blood sometimes. Maybe you had a hard bowel movement, maybe you're wiping aggressively, but if there's blood in your stool and it, persists, it doesn't go away. It's there over the course of, several days, several weeks, and it's just not going away. That needs to be investigated. That's not something you should ignore. Your stool itself, your bowel movements, if they become really thin, that's also a possible sign of a colon cancer. Other things, abdominal pain, unexplained weight loss, a change in your bowel habits. So all of a sudden you develop this diarrhea out of nowhere and it doesn't go away. It's not just like a 1 or 2 time thing, but it's, persists over the course of several days or several weeks. Certainly if it's going on for months, that needs to be investigated. Constipation as well. You have constipation, it just doesn't go away. It lasts for several days, several weeks. That needs to be investigated. So these are some of the things to look out for. And if you have any symptoms, you should make an appointment with your doctor, maybe initially your primary care doctor, and they can kind of counsel you what needs to be done.
That's good. Okay. Man, it's a lot. It's a lot. A question for me also is, you said colon and rectal. Is that the same as stomach cancer, or is that totally different?
No, it's different. Yeah, so different parts of your GI tract, and so your stomach is part of your upper GI tract. And so gastric cancer is actually really rare in America. It's more common in Japan and in Asia. But it does happen, but it's not something that I screen for. It's not something we have a screening test for per se, because it's so rare. And so if you do have symptoms you think may be secondary to your stomach, indigestion, upper, kind of abdominal pain, again, see your primary care doctor. You may need to have an upper scope done. It's called an EGD. So EGD is when they put a flexible camera down your mouth and go into your stomach and look around. And so that's not something we do as far as screening because, again, gastric cancer is so rare, but it may be necessary. So long story short, if you have symptoms, go to a doctor. Don't ignore it. Don't sit on it. We're here to help you. We're your advocates.
Yeah, cool.
Yeah, that's a mouthful and a lot that we needed to hear, Dr. Lyons. Is there anything that you would like to, are we missing or you would like to talk about before we close it up?
I think we hit the high points today. I'm glad you asked that question about the symptoms. I meant to mention that earlier and I totally forgot. And so, I just want to just send a general message about physicians in general and doctors and healthcare professionals. I kind of touched on it earlier, but I know people, specifically, folks in the Black community sometimes are, a little bit anxious or, distrustful of doctors and medical professionals. But I just want to strongly encourage all you guys, especially Black men, to go to the doctor. Beyond colon cancer, prostate cancer is also really common in the Black community. And so, the recommendation is to have an exam and a PSA, which is a lab test, done at the age of 40. So definitely go and have that done. As far as your colonoscopy, the recommendation is the age of 45. So if you haven't had one done and you're over the age of 45, go to your doctor and try to get an appointment scheduled with a specialist that can perform that procedure for you. General health maintenance, get fiber into your diet. I've been taking fiber myself every day for the last 14 years. It takes all of 2 seconds. It's not hard. And it has, major health benefits. You get 1 big tablespoon in a glass of water first thing in the morning, every morning, mix it up and drink it. And then try to focus on staying hydrated throughout the day. Ideally, I tell patients to consume at least 1 to 2 liters of water a day. Exercise. You don't have to exercise every day, but at least a couple times a week, go out for a walk. Try not to smoke. Smoking is always bad forever. Please don't smoke. And then try to minimize the alcohol. These are some simple things that you can do that don't take a lot of effort that can pay off, big time as far as your overall health and well-being. So these are just some general things I try to inform every patient, try to encourage everybody to do.
Yeah. I remember when Obama was president, the guy he nominated for it was either Secretary of Health or Surgeon General, one of them, but he had this bold goal to reduce cancer, I want to say by like 70 or 80%. And I remember hearing that, like, just initially, like, you sound like one of them quacks, that's on the nightly news.
Yeah.
But he was talking about is a lot of what you're saying,
Yeah.
preventive, like
For sure.
your exercise, smoking, drinking, and all the things that are known to cause cancer. And I know recently I read on CNN about 3 or 4 weeks ago where they were talking about even the warning that's on cigarettes, but putting that similar type warning on alcohol, because it's one of the understated things that alcohol causes a lot of those cancers too.
Yeah. Wow.
Yeah. Yep.
Yeah. So there you have it. You know, thank you again, Dr. Lyons. I just want people to really understand that this is we have one of the 5% of Black surgeons here. And so it is fewer than 5% that we have in the US of Black surgeons. So we have one of them, and even fewer, less than I think 2% in your specialty. So that's even awesome that we got you here to be able to just advocate for, you know, men of color in this space and just gut health in general, because people aren't really talking about it at all. And so it's pretty awesome to have you here on this Black History Month. We want to say happy Black History Month to everybody.
Yeah.
Black
History most definitely.
History in the making with you. We have a Black doctor on a Black-owned podcast on a Black-owned network. Shout out the Mogul TV Global. So yeah, we appreciate you for having us today. G, is there anything else?
Just one other thing. I hate to put you on the spot, or maybe I do.
Yeah.
People say I hate to, and they really mean to. So I just got notified about the men's mental health event going on again here in Vegas coming up in June. So the idea is for me and Mars. I'm gonna be there. I'm trying to get Mars. He got to get the clearance from his better half. But I hope that we can see you there too, Dr. Lyons.
Yeah, man, I'll be there. When is it going to be? Do you know the date exactly?
The 27th of June, which is, I think, is a Friday. So it's
okay.
Yes, it's going to be that Friday and Saturday. So yeah.
Yeah, you guys can see me there. I'll be there.
Excellent.
It become a yearly event. You know, I'll be more than happy to take part. And you know, thank you guys for having me on this one. I really, really appreciate it.
Yeah.
I'm just happy to be able to get the message out and hopefully make some positive change in the world.
Yeah, definitely doing that.
And March is colon cancer awareness month, just by the way. I know right now we're in Black History Month in February, and so we're going to celebrate that and big up that. But next month, the month of March, is colon cancer awareness. So just so everybody knows.
There we go. So we are right on time. We are right on time.
Yep.
Thank you for that, Dr. Lyons. I didn't even know that. So and we need to start pushing a little bit more as well. So that'd be
for sure.
There'll be less people actually going through it.
Yeah. Yep. Maybe we'll run a campaign or something to promote getting people out there to get screened. So
yeah, there's some every year. So that's the month to kind of really push it is March.
Okay. Yeah, man. Appreciate the info. Didn't know that. So Mars will close us out.
Yes, sir. So thank you guys. I appreciate you guys for joining us again on another Floor is Yours podcast. Thank you again, Dr. Lyons. And as always, G, appreciate you as well. Make sure you guys like, share, and subscribe. And we'll see you guys next time.
All right.
We gotta do it and stop talking about we trying.
I just wanna live a healthy life.
I know the benefits and how it make me feel.
I just wanna live a healthy life.
There's so much energy out here, I know it's real.
I just wanna live a healthy life.
Wake up, I got my tea boiling. Grand rising, no more good morning. Let's knock out what's important.